more easily digestible parts. We've got the bleeding disorders and thrombocytopenia here, which are going to include hemophilia A and B and vitamin K deficiency, and then some of these isolated causes of thrombocytopenia, which are DIC, neonatal alanine thrombocytopenia, and Wiskott-Aldrich syndrome. In part 2, I'm going to talk about some of the various causes of anemia. Now, these are not the only hematologic disorders that can happen in a newborn, but what I wanted to include here are some of the more common causes of hematologic problems in a newborn, and also some of the more unique things that happen during the newborn period. So this coagulation cascade is important both clinically and for the test. It's good to commit to memory. This reflects your coagulative factors, which are your factors, as well as some components here that are anticoagulative. So you have two pathways which ultimately both lead into a common pathway. The first pathway is the intrinsic pathway, and this is initiated by a damaged surface epithelium, and this involves 4 factors, 12, 11, 9, and 8. Ultimately leading to your common pathway, which is 10, 2, and 1, and 13. So when you measure your PTT, what you're doing is you're measuring the integrity of this pathway. So if your PTT is prolonged, then you know that one of these factors happens to be either deficient or not working, or there is an inhibitor. So this is what it's measuring, factors 12, 11, 9, and 8. Now on the other hand, when you're measuring your PT, you're measuring the extrinsic pathway, and that's initiated by trauma, but this only involves factor 7. So you can have problems with factor 9 or factor 10 or factor 11 or factor 12, sorry, not factor 10, 9, 11, or 12, or factor 8, but that's not going to affect the PT. It's only going to affect the PTT. And likewise, if you have a problem with factor 7, it's going to affect the PT, but it's not going to affect the PTT. So you can see here that if you have something isolated, you have a PTT problem but not a PT prolongation, or you have a PT prolongation without a PTT prolongation, then it helps you identify where the problem is at, which factor it is, or which protein it's at. So that's going to be of use to you. It's also useful to know these hepatic factors, and these are just your factors that are particularly created by the liver, and those are factors 2, 5, 7, and 10. And so when you have a patient who has has really severe hepatic disease, cirrhosis, they're going to have less of these factors, and so they are going to have an elevated both PTT and PT. Why both? Because factor 7 is going to, a loss of that is going to elevate your PT, and with factors 10, 2, and 5, those are all going to elevate your PTT. So that's why when you have a patient who's got cirrhosis, usually you'll see elevation of the PTT and the PT. These in the pink here are vitamin K dependent factors, and those are 2, 7, 9, and 10. And really the same thing here. If you have a deficiency in vitamin K, or if you're taking warfarin, which sort of inhibits vitamin K or works in the opposite direction, you're going to have a prolongation of PT and PTT because you have 7 affected as well as 2, 9, and 10. So as I mentioned, just as an aside, these vitamin K factors are blocked by warfarin, and that's why we give warfarin as an anticoagulative. However, remember that warfarin also blocks protein C and protein S, which have longer half-lives, and so the warfarin is actually going to affect this sooner. And the result of that is that when you first start taking warfarin, you're actually going to have a more procoagulative effect than anticoagulative effect, and that's what can cause that warfarin skin necrosis. And so a lot of times when you give a patient warfarin, or you want to start them on warfarin, you also start them on a little bit of heparin first until they get anticoagulated, then you can withdraw the heparin. So I talk about that a lot in the heme section. Then there's another drug that's commonly given, heparin, and that blocks antithrombin, a lot of times more particularly called antithrombin 3. And this antithrombin blocks the conversion of factor 10 to 10A, as well as the conversion of 1 to 1A. It inhibits thrombin, activated thrombin. So the result of that is also going to be prolongation of both PTT and PT, because we're affecting the common pathway here, and that works towards both of these. So hemophilia is an X-linked recessive bleeding disorder, and it's caused by a deficiency of factor either 8 or 9. The way I remember it is 8 comes before 9, and 8 refers to hemophilia A, 9 refers to hemophilia B, and just like A comes before B. So 8 or 9, hemophilia A or B. And clinically, these are indistinguishable. They both cause bleeding. They really both cause the same symptoms. However, the way we treat them is going to be somewhat different. So really the only way to distinguish these is to get labs, to get your factor levels, and to know what factor is deficient. Now, you can probably get some idea of what kind of hemophilia it is based on the family history, because these things run in families, but you really need to get labs for a definitive diagnosis. The symptoms are going to be weakness in orthostasis. That's a possibility, something a little bit less noticeable in an infant, and that's due to bleeding. But you can also see some joint pain, warmth, stiffness, particularly swelling of the joint, and that's due to bleeding of the joint. That's called a hemarthrosis, and that's one of the more common ways that hemophilia can present, and one of the more common complications of hemophilia. You can also get a headache, stiff neck, irritability, meningeal symptoms. That would be due to bleeding into the meningeal space. Hematemesis, melena, bright red blood per rectum, those would all be GI bleeding symptoms. And then epistaxis, that's another common way you can see hemophilia present in a child, or a common manifestation in a child. Because what do kids like to do? They like to pick their noses, and that's an easy way to make your nose bleed, even in someone who doesn't pick their nose. So, or even in someone who doesn't have hemophilia. Okay, so classic presentation is in about half of hemophiliacs. Remember that they tend to be boys because this is X-linked, and anything that's X-linked recessive is almost invariably going to predominate in boys. So the classic presentation is prolonged bleeding after a circumcision. Now, circumcision is not something that's necessarily commonly performed everywhere in the world. In the United States, circumcision tends to be the norm. I'm not sure the exact amount of people that do it, or the percentage, but more often than not, young boys are circumcised while they're in the hospital still. So if there happens to be prolonged bleeding after a circumcision, that should trigger you to look for the possibility of hemophilia, or at least questioning about a family history. So typically it would be like a mother's uncle or her brother was affected by hemophilia. Another way you can see it is that hemarthrosis, particularly when the baby starts to walk or crawl, and it's those instances where you start to get more injury because falling down is a normal part of walking, but in kids with hemophilia, they fall down onto their knees, they can get those hemarthroses. Something you're not going to note in hemophilia is petechiae, purpura, and ecchymoses. Petechiae, purpura, and ecchymoses are signs of platelet-type bleeding. So if you have a platelet deficiency, that's not the case in hemophilia. We have a factor deficiency. So we're not going to see the petechiae, purpura, and ecchymoses that we see in thrombocytoses. For diagnosis, you're just going to get your basic labs, coagulation studies, and factor assays. The CBC can often show an iron deficiency anemia, especially if there's been some mild bleeding going on for a long time, but that's not necessary. Coagulation studies will invariably show an elevated PTT. The PT, however, will be normal. Why is that? In hemophilia, you either have a deficiency of 8 or 9. And 8 and 9 both affect only the intrinsic pathway. And so your PTT will be prolonged, but your PT will just go along fine, because this is 7 to 10, and then 5 and 2 and 1. So none of those are implicated in your PT. So if you have a factor VIII deficiency, that's simply a diagnosis of hemophilia A. Factor IX deficiency is a diagnosis of hemophilia B. And there are various severities depending on how much factor the person has. It could be, I think clinically, the official clinical diagnostic criteria means they have to have less than 5% of normal. But if it's 1 to 5%, it's going to be less severe than if it's less than 1%, and so forth. So how do we manage this? If there is uncontrollable bleeding, of course, this would be in an emergency setting. You need to initiate aggressive hemostasis, which is going to include bandaging, immobilization of the joint or the whatever is bleeding, and then emergent imaging if necessary. You can administer factor VIII or IX, but that's only if you know that the patient has hemophilia A or B, respectively. In the hospital, you treat complications, ensure their stability. Outpatient, you're going to give, for hemophilia A, you can give either prophylactic factor VIII replacement. In more mild hemophilias, you can give desmopressin, DDAVP, which I believe can also be taken intranasally. And what DDAVP or desmopressin does is it releases stores of factor VIII, and so you're kind of putting the kid over the hill so they have enough factor VIII. Now, if it's a severe hemophilia A, that's not going to be good enough, so you'll have to also give factor VIII replacement. For hemophilia B, please remember DDAVP is not going to work because you have a factor IX deficiency, so you'll have to give factor IX replacement. And of course, these kids are going to need to avoid high contact sports because that's going to, of course, lead to hemarthrosis and other injuries. Vitamin K deficiency is a deficiency of the fat-soluble vitamin K. In infants, that's typically seen when vitamin K supplementation is not provided because breast milk is quite low in vitamin K. It can also be due to malabsorption, so if the patient has cystic fibrosis, if they've got biliary atresia, they're not emulsifying those fats, it's going to be difficult to absorb vitamin K. Remember that vitamin K is necessary for the appropriate action of factors 2, 7, 9, and 10. So if you don't have this, you're going to have prolongation of both PT and PTT because those include some of the factors that are in that common pathway. The site of absorption is the terminal ileum, and it is also assisted by normal flora. And remember that babies, when they're born, don't have normal flora. And so that's why we give most babies vitamin K supplement intramuscularly just as part of their newborn care. Now, there are babies we don't give vitamin K supplementation to, and those are obvious. Those would be babies who are actively bleeding for some reason. So in those cases, we don't give vitamin K supplementation, but the majority of babies, as part of their newborn care, we give vitamin K intramuscularly. And that's to give them that boost of vitamin K until they can start producing it on their own, getting it through their diet, and so forth. So the symptoms here are going to be factor-type bleeding, similar to hemophilia. We don't have a deficiency in platelets, but you can see in some cases some superficial bleeding as well. So it's not necessarily just the hemarthroses. For diagnosis, you'll get routine labs, coagulation studies, and factor assays. You'll generally see deficiency in factor 2, 7, 9, and 10. The coagulation studies will show both a prolonged PT and sometimes a prolonged PTT. If you see both prolonged PT and PTT, that really points to vitamin K deficiency. But it can also be other things too. But the deficiencies in the vitamin K dependent factors is really what is going to help you with your diagnosis. The bleeding time will be normal because, remember, this is not a platelet issue. The CBC can show anemia due to blood loss if that's been going on for some time. So the management, remember, we do prophylactic administration of intramuscular vitamin K to all newborns at birth with the exception of babies who are actively bleeding. Severe bleeding should be treated with fresh frozen plasma because that's got the factors, and also administration of oral or parenteral vitamin K. Mild to moderate bleeding can be treated with just the vitamin K alone. But if it's really severe, if it's internal, you want to get those factors in as quickly as possible. And then start vitamin K therapy in conjunction with that. But it takes the vitamin K some time to work. Patients who are assumed to have malabsorption, so cystic fibrosis, biliary atresia, etc., they should be given a water-soluble formation of vitamin K. It can also be given intravenously. There's various ways it can be given. Vitamin K supplementation is really important for babies who are breastfeeding, and so there are ways that babies can get that, and that's typically given by the pediatrician. Okay, so this is something totally different. So disseminated intravascular coagulation is something you should be aware of no matter what field you practice in, because you can very easily see it no matter what you're doing. So this is widespread clot formation and exhaustion of factor supply, which results in disseminated clots, which leads to thrombosis and ischemia to various organs. But it also leads to bleeding because you exhaust the factor supply and the platelets as well. So there's many different things that can cause this. As far as in the newborn period, maternal toxemia, fetal sepsis, respiratory distress syndrome, necrotizing enterocolitis, demise of twin. You can also have infections, so that can be like meningococcemia, some of the microangiopathic disorders, hemolytic uremic syndrome, TTP, Kasabach-Merritt syndrome, which is usually big spleen enlargement. Lots of things that can cause this. So half of all pediatric DIC cases occur during the neonatal period, so that's why I included it here. The most common cause of DIC in the neonate is infection and sepsis. So there's going to be bleeding, that's going to be platelet and or factor type, so you can see both. Particularly, you're going to see petechiae and purpura, and that is due to your platelet deficiency. So what's happening here is the platelets are all being exhausted. They're all sticking together, and now you no longer have enough platelets to stop other minor bleeding issues. You can also see acrocyanosis, skin necrosis, and gangrene, which is due to the clots, due to the thromboses. You can have symptoms of renal or hepatic dysfunction, again due to ischemia of the organs, and then signs of possible underlying cause, and that could be sepsis, it can be shock, and so forth. Other things that can cause this are trauma, so that can be blunt trauma, crush injury, burns, hypo or hyperthermia can cause this, severe hepatitis, pancreatitis, protein C deficiency, let's see what else, antithrombin 3 deficiency. It can also be seen in the setting of various cancers, particularly AML, the M3 version of AML, neuroblastoma. You can see it from snake bites and insect bites, but really I'm kind of getting outside of neonatology here, so I'll try to stick to our topic. All right, so common causes of DIC in the newborn, of course, the most common is infection and sepsis. Various causes of asphyxia, so respiratory distress syndrome can lead to hypoxia, and that can trigger DIC. Birth hypoxia itself can lead to DIC. Some of those more systemic disorders, hemolytic uremic syndrome, which, remember, also comes typically from an infectious agent, E. coli 0157H7, TTP, and then necrotizing enterocolitis, which, remember, you see in preemies with acute abdomen. Trauma is another cause, and then Kasabach-Merritt syndrome. So the way that this is differentiated, there's a couple things well, let me go first here to diagnosis. So of course you need to get routine labs. Your CBC is going to show a drastically reduced platelet count. You should have an elevated PT, elevated PTT. Factor assays will all be low. Your D-dimer will be high. Remember, D-dimer is a product it's a split product. So the differential here is going to be TTP-HUS. In TTP-HUS, you should see an elevated T bilirubin, but what's most important here is that you're going to see a normal PT and a normal PTT. Okay, So that's what's going to help you with the differential there. But there are some things in common. With DIC, you'll see all the features in TTP and HUS, but you'll you'll always see a prolonged PT and PTT. And generally, this is going to be in the setting of sepsis. So that's the major differential here, your PT and PTT, and the fact that this typically includes sepsis. Management is, of course, initially based on your ABCs. You want to maintain fluid status, correct any underlying cause. If there's active bleeding, you can administer fresh frozen plasma to get more of those factors. And you can also administer platelets, but that is only done if absolutely necessary. In cases where thromboses predominate and fractionated heparin can also be considered, TPA can be considered, but what's most important here is that you maintain the fluid status and that you correct the underlying cause. And then secondarily, you can manage these thromboses. If you want to know more about DIC, I talked about it in the heme section in quite a bit more detail. So neonatal alloimmune thrombocytopenia is caused by the fetal acquisition of maternal antibodies against fetal platelets. So you have these antibodies on your platelets similar to how you have antibodies on your red blood cells. And those antibodies can be inherited from both mom and dad. A certain amount of platelets can cross the placenta and get into the maternal circulation. Of course, that if the mother doesn't have those antigens on the platelet, it's going to cause a response, an antibody response. So you can really think of this in some ways as the Rh isoimmunization of platelets. It's similar in that the mother is mounting an immune response to something that's foreign, and then those antibodies are going to transfer into the fetus and cause havoc. So this is typically going to result in a thrombocytopenia in newborn until the maternal antibodies are cleared, which is usually around 6 months. This is one thing that makes us different from Rh isoimmunization. This can occur in the baby of a mother who it's her first baby, whereas with Rh isoimmunization, it takes that first sensitizing baby, and then then it can occur in later pregnancies. This can occur in a first pregnancy. The symptoms here are going to be platelet-type bleeding. That's going to include your petechiae and purpura. 30% of these babies will also have intracranial hemorrhage. So you want to screen these babies. Any baby with platelet-type bleeding, petechiae and purpura, you want to screen them for intracranial hemorrhage. The differential here includes maternal ITP. In that case, of course, the mother is going to have symptoms as well. So both mother and baby's platelets will be low, whereas with alloimmune thrombocytopenia, the mother's platelets will be fine, but the baby's platelets will be low. And then the other big one is congenital infection. And usually with that, you'll see other stigmata of infection. Rubella is the one we think of. That's the one that usually presents with that characteristic blueberry muffin baby. But in that, you'll also see some other signs of congenital infection, which in rubella includes cataracts, low birth weight from intrauterine growth retardation, and microcephaly, as well as some other things. For diagnosis, it's really highly suggestive if you have thrombocytopenia in a baby who is otherwise well, and the mother has a normal platelet count, and there's no congenital infection that's likely. So you kind of have to exclude some things. You have to exclude congenital infection, and you have to exclude maternal ITP because the mom's platelet count has to be normal. If mom's platelet count is normal, there's no cause to think congenital infection, and the baby has low platelets, but is otherwise healthy, doesn't look septic or anything, then the cause is most likely neonatal alloimmune thrombocytopenia. And I'm sorry, this should all say NAIT, not NAIP. I don't know how I screwed that one up. All right, so formal diagnosis. That's going to require genetic testing of both mother and father, and that's more important for future pregnancies. Uh, as far as the baby goes, when we can't really predict this in a first pregnancy, and once the baby's born, there's really nothing that we can do other than supportive care, maybe platelet transfusion, maternal platelet transfusion, preferably. But once the baby's born, there's really nothing we can do. What we can do, though, is help prevent this, and that's going to require genetic testing of both mom and dad, prospective dad at least, and then assessing the mom for specific antibodies that are related to NAIT. The management is, of course, for the baby, just observation. If platelet counts are really low, you can use washed maternal platelets. And it's good to use the maternal platelets because mom gave baby antibodies, but it wasn't antibodies to her own platelets, it was antibodies to baby platelets. And so what better to give the baby than mom's platelets that you know the antibodies aren't going to work against. And then definitely remember to get a cranial ultrasound. As far as the mom, management for her is going to be done by an OBGYN, and that's regarded towards future pregnancies. So if she has a history of giving birth to a baby with NAIT, then she should be given IVIG during the second trimester, and then the baby should be delivered via C-section. You can do prenatal sonography to look for signs of intracranial bleeding, both prenatally and postnatally. And then a cortocentesis can be drawn to determine fetal platelet levels. These two things are not necessary, but this, the IVIG and the second trimester and the C-section are part of routine care for preventing NAIT only in a mother who has a history of giving birth to a baby with said disease. Wiskott-Aldrich syndrome is an X-linked recessive condition, so again, something you're going to see more often in little boys, and it results in this triad of impaired platelet formation, eczema, and severe IgM deficiency. So this is one of your congenital immunodeficiencies, and it's actually a combined immunodeficiency because it also happens to affect the T cells as well. The early manifestations are going to be related to the thrombocytopenia. So you'll see petechia and purpura, you can see bleeding at the circumcision site, you can see epistaxis, surface bleeding, bloody stools. Then beyond that, the baby's also going to have a predilection for illnesses, and that's particularly going to be illnesses from the encapsulated bacteria. So strep pneumo is a big one. And so this baby will have a predilection for ear infections and pneumonia. And then eczema is another prominent feature of Wiskott-Aldrich syndrome, and that likes to accompany the illnesses. So when the baby's ill, they have a breakout of eczema, but you can also just get the eczema at other times without infections. And the eczema itself is a problem because eczema disrupts the skin, and when the skin is disrupted, you have a higher risk of infection, and you combine that with the fact that the kid's already immunodeficient, and you can see why that would make things even worse. So for diagnosis, of course, you need to start with the CBC. That'll reflect thrombocytopenia. That's absolutely critical and necessary for the diagnosis of Wiskott-Aldrich. And you'll want to also get a visual analysis of the platelets because if you suspect this, the platelets in Wiskott-Aldrich syndrome are abnormally small, and that's really characteristic of this syndrome. There's not a lot of things that cause that. A quantitative serum immunoglobulin level is necessary for diagnosis, and I believe this would be the most accurate way to diagnose Wiskott-Aldrich in the setting of the patient's symptoms. So remember, we have an IgM deficiency. So you get that serum immunoglobulin levels, and the IgM levels will be low, whereas the other IgGs, A, D, G, E, those will all be normal or elevated. So the way to management, we need to, of course, send these kids off for multiple referrals because this is a systemic problem. They're going to need to be managed by a hematologist because of the bleeding issues. They're going to need to be managed by an immunologist because of their immunodeficiency. When they're in the hospital, a lot of times because they can have more problematic, more rare infections, especially as they get older, they're at predilection for pneumocystis jirovecii pneumonia. They may need consultation with a infectious disease specialist. So really this is a multidisciplinary approach. As far as the bleeding issues, you can manage significant bleeding with platelet transfusion. If there's anemia, which a lot of times there is from chronic bleeding, you can give packed red blood cells. Splenectomy can be useful to control platelet levels. Now, this is sort of a take and give. So if the kid has real significant common problems, more than that beyond the typical kid with Wiskott-Aldrich syndrome, with their platelet levels and they're constantly bleeding, and this has really become a serious issue, then you can do a splenectomy, and that really does help with the platelet issues and with the bleeding. However, what it does that is not desirable is it heightens the risk of infection. And remember, you're already dealing with kids who have an inherent immunodeficiency. So splenectomy can be useful, but you really have to consider the risks and benefits. And of course, with any bleeding disorder, you should avoid high contact situations. As far as the infections go, these kids can get vaccinated with dead vaccines only. You're not going to use live vaccines, so they're not going to get an influenza vaccine or chickenpox vaccine. But the problem is it might not be good enough because remember, you have to develop antibodies in order to get an immunity. It's not just the vaccine. You have to actually respond to it. And these kids are immunodeficient. So it may not work, but there's no downside to giving them dead vaccines. Whatever level of immunity they can get is better than nothing. These kids are usually also given IVIG therapy and prophylactic antibiotics. And then post-exposure prophylaxis can be given as necessary. So you think of things like giving tetanus toxoid if they're exposed to possible tetanus. You think of things as giving varicella immunoglobulin if they're, which I'm sure this will happen no matter what, they come into contact with another little kid that may have chickenpox or has chickenpox. So those things can be done too as more of a secondary prevention. The eczema can be managed with topical corticosteroids such as fluocinolone. Also important to make sure that you're keeping good cleanliness of the affected areas, making sure that they stay moist and not in a situation where they may become infected. So that's also very important. And then surveillance for malignancy will be useful, and that can be done by the hematologist. The most common malignancy that occurs in these children is non-Hodgkin lymphomas. The only curative option is bone marrow transplant. So lots of things to do. These kids get sick a lot. They have a lot of problems. So this is definitely something no parent ever wants to have their kid born with. But we do have a management plan. So when you're looking at coagulation labs, we talked about these things. There's some things that we didn't talk about, like liver disease, heparin, and warfarin, but I kind of alluded to them. Always important to keep in mind these things that you have as part of your labs that are at your disposal, and that includes bleeding time, which is going to correspond to the platelets, your PT and PTT, which is factor related, and then of course your platelet levels, which is part of your CBC. So hemophilia A and B and vitamin K deficiency, those are just factor problems. Vitamin K helps with the production and the operation of the factors. Hemophilia A and B are both deficiencies of factors. And remember, hemophilia A and B only affect the PTT side, so only the PTT is going to be affected. Platelets are normal, bleeding time is normal. With a vitamin K deficiency, that's going to affect both sides, both the PT and the PTT. With DIC, it's a consumptive coagulopathy, so everything is going to be affected. Platelets, factors, and that's going to increase your bleeding time and so forth. With NAIT, it's going to affect your platelets only, so your platelets will be low, your bleeding time will be elevated, but your PT and PTT will be normal. And then, as we mentioned with Wiskott-Aldrich, the platelets are low, so that's going to cause an elevated bleeding time, but PT and PTT should be normal.